Welcome to the Delaware OBGYN Resident Lecture Series, a series of short lectures for our residents here at Christiana Hospital in Newark, Delaware. This is a summary of Committee Opinion 692 for April 2017. If you can only stay for the first 30 seconds, here's the bottom line. Labetalol and hydralazine have long been considered first-line therapy for acute hypertension in pregnancy, but now, with this committee opinion, immediate release oral nifedipine is considered first line also. For those of you who are going to stick around for more, we're going to talk a little bit about when you treat acute severe hypertension, why you treat it, how you treat it, and what you do if it doesn't work. First, you treat acute severe hypertension as soon as you diagnose it. Measure the blood pressure in a semi-reclining or seated position. Don't roll to one side or the other. If the systolic pressure is 160 or greater, or the diastolic pressure is 110 or greater, repeat in 15 minutes. Persistence for 15 or more minutes constitutes acute severe hypertension. Now treat that within 30 to 60 minutes. Of the systolic pressure, the mean arterial pressure, and the diastolic pressure, it appears that the systolic pressure is the most important predictor of cerebral injury. The Confidential Enquiries report from the UK noted that 2/3 of maternal deaths from 2003 to 2005 resulted from cerebral infarction or hemorrhage. Nearly all were preceded by systolic hypertension in the severe range. Only 13% had severe diastolic hypertension, suggesting the systolic hypertension is a more sensitive indicator. The goal is to prevent cerebral injury and in turn reduce maternal death. This means getting the blood pressure out of the severe range, not to the normal range, but out of the severe range. The goal is out of the severe range and into the 140 to 150 over 90 to 100 range. Quote, in order to prevent repeated, prolonged exposure to severe systolic hypertension with subsequent loss of cerebral autoregulation, end quote. Now that sentence is the type you usually skim quickly and think, just tell me what I need to give and when. The committee opinion doesn't really get into it very much because it's a committee opinion, not a review article, but I think it's the most interesting part of the whole thing, and since this is resident education, we're going to talk about it, damn it. There are two aspects of cerebral autoregulation that are pertinent in preeclampsia, altered and absent. First, let's oversimplify the whole thing and talk about what happens to cerebral blood flow in response to mean arterial blood flow. When the mean arterial pressure drops, cerebral arterioles, and even large arteries, dilate to maintain flow to meet the high metabolic demand of the brain. The brain needs a certain amount of milliliters per gram of brain tissue. So when you're taking a shower and the water pressure is good, you've got your knob or knobs the way you have them every morning. Now, when everybody else in the house gets up and turns on a shower, flushes the toilet, or brushes their teeth, the pressure drops and you respond by opening up the spigot. But wait, doesn't that make the pressure drop further? Yes, a little bit, but you don't care. You have shampoo in your hair, you're late for work, and you need all the flow you can get. You are auto-regulating. You are doing what you have to do to get what you need. But I thought constriction made the pressure go up. Yeah, if everybody closed the spigots a little or a lot, or if all the blood vessels in the body constricted, but you definitely would open up the water if you noticed the shower lost pressure. Cerebral vessels dilate when the mean arterial pressure drops and prevents ischemia. Once the cerebral perfusion pressure gets down to 60 millimeters, they're maximally dilated and flow just drops after that. Okay, next thing you know, everybody's done showering and pooping, and the shower just about blows your eyeballs out, so you quickly close the spigot to reduce the flow. Cerebral arterioles constrict as the mean arterial pressure increases up to a cerebral pressure of 160 to keep cerebral blood flow relatively constant. After that, the smooth muscle of the arterioles can't hold back the pressure, and the flow goes up anyway. Wait, isn't more blood flow and oxygen even better? High flow and pressure and its high hydrostatic pressure drive fluid through the endothelium and into the interstitial space. It can also disrupt the endothelium and blood-brain barrier, forcing out fluid and proteins, and all hell breaks loose. This interstitial fluid is responsible for hypertensive encephalopathy and posterior reversible encephalopathy syndrome, or PRES, and eclampsia. In the extreme, cerebral edema can result in brainstem herniation. Okay, so that's cerebral autoregulation, and it follows the curve. The first way it works into the committee opinion is when it says, quote, the goal is not to normalize blood pressure, but to achieve a range of 140 to 150 over 90 to 100. This is most important for patients with chronic hypertension who have had elevated pressures for so long that the smooth muscle of the vascular wall hypertrophies and shifts the curve. They can handle high pressures better, but low pressures worse, and the cerebral flow drops when the arterial pressure has dropped all that much. This can lead to ischemia. Incidentally, this can happen elsewhere, like in the coronary arteries. So the goal is not aggressive normalization. This is altered autoregulation, where the curve is shifted. That's the first aspect of cerebral autoregulation. The second is not merely alteration, it is loss of autoregulation, seen with persistent severe range blood pressures and disease states like preeclampsia and stroke. Here the plateau portion is lost and flow increases directly in response to increased pressure, which can allow dangerously high flow even at not so dangerously high blood pressures. Okay, enough about autoregulation before someone sticks a fork in their eye rather than hear any more of this. Treating high blood pressure is important. We get it. How? Traditionally, it's been a labetalol regimen that ends by switching to hydralazine, and a hydralazine regimen that ends with labetalol. So let's start with those regimens and finish up with the nifedipine one. You should know the basic timing, dosage, and side effects of the meds. Give hydralazine about 20 minutes to work. Give labetalol about 10 minutes to work. Give nifedipine about 20 minutes to work. I won't use pharmacokinetic terms here because I don't know which ones I would use. But don't give hydralazine sooner than 20 minutes because it hasn't kicked in and you might bottom her out. Also, don't wait longer than that amount of time because if it's going to work, it probably has by then. Same idea for the others. All three regimens start by establishing the need to treat by diagnosing acute severe hypertension, systolic blood pressure over 160 or diastolic blood pressure over 110, confirmed 15 minutes later. All three are considered first-line therapies. With the hydralazine one, start with 5 to 10 milligrams, slow IV push over 2 minutes. Both hydralazine and labetalol are given this way. I prefer to start with 5 milligrams in a patient who hasn't seen hydralazine before. If she receives some hydralazine a day or two earlier and tolerated okay, then start with 10 milligrams. So give 5 or 10 milligrams, then wait 20 minutes. If the systolic blood pressure is over 160 or diastolic over 110, give 10. Wait another 20 minutes. If still severe, switch to labetalol, 20 milligrams IV slow push. Switch to labetalol, 20 milligrams IV push. Wait 10 minutes. If severe, give labetalol 40. Wait 10 minutes. If still severe, consult MFM, critical care, or anesthesiology. For labetalol first, start with 20 milligrams, wait 10 minutes. If severe, give 40, wait 10 minutes. If severe, give 80, wait 10 minutes. If still severe, switch to hydralazine, 10 milligrams, and wait 20 minutes. If severe still, consult some help. For nifedipine, start with 10 milligram immediate release capsule. Wait 20 minutes. If still severe, give 20 milligrams orally. Wait 20 minutes. If severe, switch to labetalol, 40 milligrams IV, and then get your consults. All three are first line, so which one do you pick? Based on some characteristics of the drug, evaluate the clinical situation and use those characteristics to pick. Hydralazine can cause tachycardia, so can nifedipine, but it can also improve urine output. And it's okay to use nifedipine with magnesium sulfate. Labetalol blocks beta 1 and beta 2, but also has some beta-mimetic effect, which is why it is less likely to cause bradycardia than propranolol, but can still do it. Its beta-2 blocking effect can exacerbate asthma. So, think about labetalol for someone who has a pulse over 100 or someone who is already on PO, hydralazine, or nifedipine. Think about hydralazine for someone with asthma, a heart rate under 60, or who has been on other PO meds. Although not mentioned in this committee opinion, some will choose labetalol in the setting of a high pulse pressure and the afterload reducers, hydralazine and nifedipine, with a low pulse pressure, where the diastolic component is a bigger contributor. Think about nifedipine for someone like the person described for hydralazine, but also the person with low urine output. Especially think about PO nifedipine for the person who comes in with severe acute hypertension and you don't have IV access. If these first-line therapies are not effective, consult HELP, who will probably consider nicardipine or esmolol infusions in an intensive care setting.